I think what I'd first like to do is to introduce everybody who's here as part of the Alliance. And whenever you want to speak, if you pop your hand up, I'll call you in, and just if you'd like to say who you are and what you do, that would be great. First person I can see on my screen, I mean, myself, I'm Claire Stevens. I'm a GP by background, had a long, spent many years doing a combination of clinical practice and clinical commissioning. And I'm the co-clinical director of the North Central London Cancer Alliance. And we're giving this webinar today spanning across the Alliance and our ICB. So, and I've got with me here today Amelia Robson. So Amelia will wave. Say hello, Amelia, and what you do.
Yes, I'm Amelia, and I'm a senior project manager in the Cancer Alliance, and I've been working on some of our activities around FIT. So great to see you all here.
Thank you so very much. And who else can I see on my screen? So we've got Ariana, part of our team.
Hello, I'm Ariana. I'm a junior project manager working for the Cancer Alliance on primary care and just helping support with some of the FIT work.
Thank you. And Seema Chowdhury, who's all things FIT for the Alliance. Hi, Seema.
Hi, my name's Seema. I'm the GP lead for FIT and FIT Pathways in the NCL Cancer Alliance, and I'm also a GP, salaried GP in Islington.
Great, thank you so much for being with us today. And James Harris.
Hi everyone, I'm James. I'm a program manager within the North Central London Cancer Alliance, and I'm responsible for the work on FIT.
That's great. I think that's it for our side of things. I think, is that right, Amelia? Yep. Great. Okay. So straight in, and I actually, is Caroline here? I couldn't see her, but if she's here.
Yes, I'm here.
Brilliant, Caroline. Thank you so much. So Caroline is a really senior practice manager in NCL, and she has been doing some work with us with practice managers from all of you from across our geography and the admin teams that support you to try and help us develop and take forward our various work streams related to cancer and primary care. And this is about FIT coding, which is one of our challenges at the moment. So Caroline, please introduce yourself.
I think that was a great introduction. So quite familiar faces. I see quite a few friendly faces there from Barnet. I have had the opportunity to work along with Cancer Alliance. As many years as I've been in Barnet, I'm learning loads. And I just want to, as a non-clinician, try and help with the uptake and improving systems and just make it all understandable so that all practices can engage.
Thank you. Thanks so very much. Okay, so let's go on to our next slide. Thanks, Maria. So this is what we're going to cover in the agenda. We're going to do some background on FIT. We're going to have a practical session that Carolyn's going to lead on code matching for FIT, and we're going to explore how FIT fits into our pathways as appropriate for all of you in the admin side of general practice. Thank you. Next slide. Okay, so just to quickly for everybody, who are we in terms of the Cancer Alliance? So we're the North Central London Cancer Alliance. London has got several alliances within it, and within it we divide up the whole of the geography, and there are 21 alliances in the UK. The Alliance brings together patients, hospital trusts, GPs, health service commissioners and local authorities to improve cancer outcomes and care. And we cover the boroughs that you can see in there, which are also your boroughs, the pink boroughs of North Central London. We're all about identifying innovative changes and improvements in diagnostics and treatment for cancer. We lean into the whole of the pathway from presentation in primary care through to secondary care, through to tertiary care and onwards into recovery and beyond cancer diagnostics. Thank you. So next slide. Okay, so a little overview of what we've been doing. Here are our aims for 24-25. we are aiming to improve our early diagnosis of cancer. That's cancers that are diagnosed at stage 1 or 2 by 3% in the 24-25 year. I know 3% seems a low number, but it's a really lots of hard work are required to improve our levels of early diagnosis. And it's in fact a challenge and a job for all of us, and particularly in primary care, getting better at identifying people when they come to general practice for all sorts of reasons, and making sure that patients are complying with screening and are able to access the medical staff in practice when they request, when they're concerned about cancer. So we need to get all those things right to be able to improve our early diagnostic rates. However, we are very good as a general performer in terms of the whole country, and that's down to everyone's efforts across the whole pathway, but particularly those people in primary care. So thank you for that. In terms of the Cancer Alliance, we've got some priorities. We've picked 3 main cancer priorities for this year in terms of trying to improve our referral rates and improve our early diagnostic rates. So that's this year we've chosen lung, bowel and upper GI. And in terms of bowel cancer, one of the most important things we can do is maximise the usage and appropriate usage and appropriate recording of FIT, which is the fecal immunochemical test, which is that little test. I'm just looking to see if I've got one to wave at you. I haven't, but it's that little green tube with a green top that you see floating around in practice, and that's the FIT test. And here there's a little bit of information at the bottom of the slide on our outcomes, and I'll leave you to read that, but essentially we're aiming to meet the NHS long-term plan ambition of diagnosing 75% of cancers by stage 1 or 2 by 2028, and we'll only do this by a whole system approach. So thanks very much for joining us on this journey. Next slide. Okay, so I think I'm going to hand over now to Seema, and Seema, as she said when she introduced herself, spends a lot of time doing FIT for us across the geography. And if you ever got a query on FIT, the person to speak to is Seema, or otherwise, if you can't reach them, then any of us will try and help. But thanks very much, Seema.
Thanks, Claire. Just want to talk a little bit about what a FIT test is. So what is a FIT test? A FIT tests for blood in poo, and it produces a score based on the patient's sample. For symptomatic patients, the risk of colorectal cancer in those with a negative FIT test, a normal FBC, that's the type of blood test, comes up to less than 0.1%, which is actually lower than the general population risk. So it's a very reassuring test all round. All clinicians should be using FIT tests to guide referrals for suspected lower GI cancer, and therefore the test should be done prior to referral as part of the initial workup. And that is unless a clinical exam has revealed an anal mass, a rectal mass, or anal ulceration. If any of those 3 things are found, then that patient should be referred straight onto the suspected cancer lower GI pathway without needing a FIT test. Therefore, a FIT test should be completed within the 21 days prior to referral on the suspected lower GI cancer pathway. In NCL, we've had historically challenges with data on our FIT uptake. Data has shown that our use of FIT has been below the national target of 80%. However, it is gradually coming up, and that's due to all of your hard work with this. However, we want to make further improvements on this. So why is it important to use FIT effectively in primary care? So making use of FIT tests plays an important role in following the NICE NG12 referral guidance. And this also helps to improve the system capacity by reducing unnecessary tests like colonoscopies, which are also quite invasive. Patient experience will also be improved by reducing unnecessary invasive tests. Using FIT tests also supports earlier diagnosis through making better use of this diagnostic capacity. And it can be used to inform decisions to refer patients for colonoscopies, therefore protecting the capacity for patients who do actually require a colonoscopy, those who are higher risk of having colorectal cancer. Next slide, please. Thanks. So we know that the uptake of FIT tests varies by practice and also by borough. There have been shifts in performance levels between data which we have received over time. Overall, Haringey and Islington remain probably two of the most challenged boroughs in the NCL area in terms of FIT uptake. However, like I said earlier, there is definitely room for more improvement across all the boroughs in NCL and for meeting the national target of 80%. You can actually access data on your practice, and that's through the PCN dashboard on the ICB website. I think the link is probably in this presentation, or we can put it into the chat. And by accessing that PCN dashboard, you can look at your own practice uptake, you can look at your PCN and your borough uptake and compare. And this is something that is updated monthly, so it's actually a really useful bit of information to monitor how we are doing. Thank you. Next slide. And I'm going to hand back to Claire. Thank you.
Right, I've just got a short bridging slide between Seema's presentation and then our next set of slides, which Carolyn is going to take you through. And the other thing I wanted to say is we want this to be a bit of a conversation. So although we have got a special questions section at the end, we'd be really happy for you to ask at any time. If you just raise your hand on Microsoft Teams or wave if you think that your yellow hand can't be seen, and then we'll ask you to ask your question. But so as we pass, having understood the background to FIT, as you will, I know you'll have found that quite clinical, but we really felt it was important for you to hear how FIT needs to be used clinically so that you can work and support your clinicians in practice doing that. The next part of our job to improve our FIT usage and make sure that we record it properly is to get the coding right. And coding is a really big challenge in NCL. We know there are lots of issues that explain why coding isn't completed in its ideal form. And some of those we can affect and some of those we can't. So we're keen to explore how people are finding the coding of FIT, if there are issues and if there are solutions that some people are using, we'd like to hear about them. We've also got several solutions ourselves, and Caroline will take you through that. So let me just move over to Caroline and leave the floor clear for her. Caroline, thank you very much for coming and talking about this, and in fact for leading this group, which is excellent in terms of all our practice managers and admin staff in NCL who are interested in primary care and cancer. Thank you.
You're very welcome. Thank you. I think I suppose I'm just going to share with the Cancer Alliance, working with them, I'm learning stuff every time we meet. And I think there is a little bit of their understanding of what they think we know and what we do know. So I didn't know about the PCN dashboard, and that could be the cancer dashboard, that could be my fault. You may all be familiar with it, but I think it's well worth a visit. When I was looking at it, I just thought it's ideal for CQC. This would be able to measure, look at your quality improvement programs and what changes are you making, and look at your benchmarking in your PCN and other practices. So use the link that Amelia sent out there in the chat. I think it's very, very important. She's also put a form there saying to add your information. I think it would be worthwhile adding your name to this. Then you can get invited to more of these type workshops that will help your practices move forward and get information. So just fill in the form, very simple. If you filled it in before, it's okay. They will be able to deduct any duplicates. I was looking at fit testing. I didn't quite understand all of it, so I really appreciated Seema taking the time to explain it all to us and why we do it. What was important to me, I think, is if we want to increase the uptake, we've got to change what we're doing. So in my practice, I am looking at working way to know that every time a fit test goes out, or we ask a patient to do a fit test, are they actually doing it? So I used a very simple form using an F12 function to code it so that I can run then some searches and then pull these patients out. And then I'm using my care coordinators to try and encourage patients and finding out what the barriers are, because it seems to be this fit test really does help them determine what they need to do. So that's something, if you're interested in that, we can do more work in that. I can share with what I've done, but put it in the chat if you're interested in going down that route, and we can do it in another session. I just want to look at the coding here. And again, for those of you who have done this, that's great. I have done it now, but I wasn't quite sure I had done it at the time when this came up. So your fit testing goes out, it goes to the lab, and when it comes back into EMIS, it was getting coded under different codes which weren't matching up, and it's not, your data's not getting picked up. So what we want to do is go and identify any test results that have come back in and are not correctly coded, because once you've mapped them over once, they'll automatically be mapped over properly the next time. So it's just a really housekeeping, it doesn't take very long, and if everybody does that, that would already improve on your results. Yeah, Amelia, jump in.
Hello, just to say, if you let Ariana know when to change slides as you go along, we'll just make sure we're all looking at the right thing at the right time. But yeah,
that's fine. Yeah, thank you. So where do we find these codes? So from your main menu, you're going to go to your workflow manager. You can see this in the screen. So we look at number 1, you're going to click on the config, which is your little cog. So that will then drop down, and we're going to look at the option to pick. See number 2, it says inbound code matches, and anyone who's got their EMIS open, by all means follow along, and you'll see how straightforward it is. Number 3 tells us that all of these tests that are displayed are unspecified, they're not matched, they're not coded, and the one we're looking at is the FIT, the FIT. You'll see that they need to be matched to a SNOMED code so that they can be lifted out. And option 4 on here, you can see there are 3 types of codes that sometimes the labs are sending them back. And these are the ones that we want to know if there's anything sitting on your system underneath these, and can we map them across. So you'll see that the quantitative FIT and the quantitative immunochem test, slightly different. And then you've got your FIT test. So these are what we're looking for. You go along and you actually find, let's start with the one here that's highlighted is the FIT, which is the bottom test. So you're going through. Now this is a little bit of work in the fact it takes a bit of time. There'll be a lot listed there. So you do have to sort through. They're not really they're not in alphabetical order or anything. But be patient, find this particular wording. And then you're going to highlight it, and then you're going to use the code matches option to edit it. So we go to the next slide, please. So by editing it, what we're going to be doing we're going to assign a code to it. So once you hit on edit, you go over to number 6 here, where you can say this QFIT term is going to be matched to it, and you're going to select the code. So you use the spyglass for your code selector, and then you type in the search box what you're looking for. When you've searched for it, number 7, you're going to do, it's the same thing. You're going to pick up the test, and then you're going to press OK, and that will connect the code over. You can see number 7 and what it's actually searching for. We've searched for it and what it's actually going to attach it to. And then you're going to click OK. If we go down a little bit, Next slide, please, sorry. And then you're just going to say, okay, so what you've done is you've got this is the inbound, this is what it's come as, this is what I'm matching to, and in future, anything coming in with that term will be matched to this. And that is the correct code that we want, SNOMED code. Now, as we said, that's only one area. If you can flick back up a couple of slides. You see there was 3, if you look at option number 4 here, there's 3 different areas. You need to repeat the same process for each one of those. So you go through, use the spyglass, pick it up, and then you match it to the code. You edit and then you match it. So you just use this guide and just follow it through. That will pick up all of those and link them. And in future, when anything comes through, it will automatically be coded correctly under SNOMED. Any questions? Smita's saying sure. Okay.
Caroline,
Yeah.
Yes, I'll bring Smita in a second. There was a question, a comment from Riz Hussein saying they couldn't see it in the list. But
it may be that you've already actually done that. Because
okay.
and I recall, if you do recall, we had a problem. We were doing the IIF a year or so ago, and the fit testing that had to be done within the time frame, and we were monitoring them on Ardens were coming up, and everybody couldn't understand, and they were checking it all. And actually, one of the solutions was to go and do this coding. So some of you may have already done that to fix your IIF, but there may be some practices that are outliers that didn't get that information. So this is going to be for them. So if you haven't got that code, Riz, you probably did fix it at the time.
Okay, and let me bring in Smita. Smita, you had a question.
Hi, Caroline. In our practice, we do lots of fit tests, but I had a meeting with Seema and our upload is only 33%, which is, concerning me. So I discussed with our clinical leads and they just said that when we issue this fit test, it's automatically read code. Is that correct?
Okay, I didn't quite follow that, Smita. So go again.
Sorry, I just spoken to one of our clinical lead who does this fit test, and I asked him that why you not entering, SNOMED code? And he goes, no, Smita, when we issue fit test, that time automatically this read code download. I said, are you sure? And I wanted to, just curiosity, I wanted to just know that is that correct or no?
Now, my understanding is that free text codes free text is not going to be coded this way. This is they're like channels. When you put a test and it goes to the lab, they have a channel of how they put their information back into the practice. So when it comes into the practice, it's just, I'm not sure why, but I think it's the lab choose a different option. And when they come into EMIS, this is where you might get these other codes are being used. So we're just tidying them all up and whatever way they've come in, they're all going to be linked to the correct SNOMED code.
Okay. So how can you tidy up that all incorrect read code which we receive from lab?
Well, that's just what we've just done. When you go through that process and you find them as search and you link them, they will then automatically, any of your codes will be linked to that new SNOMED code.
Sure, I will do that. No worries. Thank you.
Let me bring in Jackie Tong. Seema did have a hand up, but it's gone down again. So I'm presuming the question's been answered. Jackie first, and then I'll come back to Seema if she wants to say something.
Oh, thank you. I just wanted to ask, we're like Riz, so ours I couldn't see it on our list, and I think it was when we were doing the IIF. But in the chat, somebody's put that all matched and unmatched inbound codes will be on the list, should appear even if it has been matched. So I'm not sure if there's any sort of IT guru on here who knows what's what, but I'm assuming ours is fine anyhow.
Yeah, my understanding, Jackie, is exactly that. If the codes came in and you've got those 3 different codes coming through and you match them to that, they will automatically match to that going forward. So you wouldn't have to do it each time and you wouldn't have to repeat it. It's a bit like the bloods when they come down through the lab links and you find one that's not been coded and we attach it, it gets done forever, doesn't it? We don't have to go back and unmatch it.
Yeah, so it doesn't matter that they're not showing on the list. We're done.
But they don't show the list. It's because there's nothing there that's sitting that hasn't already been matched.
Yeah. So I think that comment perhaps is slightly confusing people in the chat then.
Yeah, I agree. Yeah,
Thank you, Caroline. Thank you.
you're
Thank you,
welcome.
Claire.
Oh,
And
Tanya, sorry, I
Tanya,
missed you.
yeah, Tanya's got a question. Tanya, please say your question. I think you're on mute. If you can't speak it, can you put your question in the chat and we'll go on. So she may have just stepped away from the mic for a sec.
Yeah, sure.
Caroline, do you need to for everyone on the group, is it worth just repeating what you were saying again about the that kind of dialogue between you and Jackie around what's the sort of the absolute truth about those codes? So I know there was somebody said they thought they were all on there, but what you I think were saying was that the system will remember when you've removed them.
If we go to this slide and look at number 4, there's 3 types of codes or 3 narratives coming in saying this is what's inbound has come through your system, and those 3 codes are not mapped to anything. They're not mapped to a SNOMED code. This procedure, when you follow it, picks that up and says, when this one comes in through the channel, please make sure that it maps to the correct SNOMED code. So you're only going to have to do it once. So when you go through and you map all of those 3 comments to this SNOMED code, you won't have to go back and do it again.
Okay. So you'll only have to do it if some clever clogs at NHS England thinks up a new code.
Yeah, if they come back and we find there's a problem and they come up with a new code, then we'll have to go back in and edit and attach those across. But I think the lab is working really hard now to try and stick to these ones, not to. I think that's a case of 5 people are asked and they have a drop-down list and they send it back with whatever one they wanted to. So I think it's a little bit more streamlined now. So if you do this mopping up exercise, we shouldn't have to revisit it.
No. Okay. So I can see that Tanya's struggling with her mics to make it work. But if you want, we do seem to be able to see your chat comments, Tanya. So maybe put the question in the chat if you like. I think if there's a pause for a minute, Caroline, I wonder, Caroline, if you wanted to talk about the work that you've been doing in your practice using the F12 key to try to help with FIT.
Yeah, sure. Tanya's just come back, so she's just saying she's saying that she's looked at the list several times, she can't find them. So again, I'm going to say that if that's the case, then you've probably already mapped them across, or somebody did, and probably during IIF, which is great. So that's it. And I think somebody said here, if you go in and look at a recent fit test, you can actually see the code, the SNOMED code it's attached to. So that means it's done. Yeah, so you should be able to have a check on that. So I think that's it. So basically, when we were talking about fit testing, my understanding is that the patient is asked to go and do the fit testing, might have to do bloods, and then the GP then may make a decision on depending on the results coming in, and then refers them on with their 2-week wait. So it was like, what would be the barriers to getting the fit testing, and particularly today now, understanding much more about how important it is to get the fit test and what that information is helpful for the clinician and for the patients to go down the right pathway. We were looking at a system of how we could monitor this, and there's no SNOMED code. You can't search on these diagnostic codes. And so what we did, we created just a little macro from F12, and it's every time a fit test is requested, we hit F12, and then it captures the information to say that a fit test has been requested. We know that we want to follow up on that patient, so we've run some searches on that particular code that macro records, and then we can go through this and have a look, whether it's every week, just to check that the people last week that were asked to do it have actually returned their fit testing. We've got a result. What we found, we could send out a gentle text reminder, and then after we're doing it twice, 2 text reminders, and I'm not really sure that's going to be helpful because we'd like to try and get them done quicker. Maybe we might reduce it down to 1, but we then had some care coordinators who phoned up the patients to try and find out, had they lost their packet, had they forgotten, did they understand, were they video to show them how to do it, because at the time they were a little bit left the GP thinking, oh wow, I've got to do this, and they're not quite sure what they're doing. So we were finding that they were giving us reasons, explanation, and we're hoping that that will increase the amount of fit tests that are coming back, or at least identify what is the reason why people won't do them. Because if they're so helpful for the clinicians, then the patients need to understand that. So that was just something that was willing to, not everyone has to start from scratch. I'm quite happy to share how we set the F12 up, quite happy to share we can upload our searches that we're using just to make it simple.
It sounds a really good idea. I mean, for all the people that are on the call today, do any of you use Fit12, the F12 key in that way? Let's put it in the chat if you do. No, yeah. Jackie said no, yeah.
Yeah.
So Susanna uses it. She's at the Highgate practice.
Yeah.
So you do have to set it up to make it work for Fit.
Yeah, but it's very straightforward. I
Yeah.
mean, we use it for things like flu jabs every year. If we
Yeah.
want to make sure everybody who's doing the flu jab, instead of having to go into a template, you hit F12 and say flu given, and it codes it. It's just a quick way
Makes it easier.
to catch
Yeah.
it. Makes it easier, and then people are more inclined to do that rather than have to access a template and then they forget. And it just means we have the data to try and then see if we can help.
Yeah,
Patients.
so I guess what we're asking, it's a suggestion, as it's been so helpful for the practice in Caroline's PCN, it might well be helpful for you if you don't already use it. I think that most people probably use the F12 key for one shortcut or another,
Yeah.
but adding the Fit to it might really help your clinicians, and particularly your maybe also your locums or doctors that are only working very part-time. Because it's a simple, easy request to hit the F12 key, isn't it, Caroline? And then everything will lead from there.
And I do think that is a little bit of safety netting, because that is always one of my concerns. If you're busy practices and you have locums coming in, how do we track them through? I don't know whether the locums would ask for the fit testing and then you're expecting your clinicians to pick them up through the results coming through. Would this be a better way to safety net it? Just double checking it all so we can capture.
It's searchable, isn't it? So I guess that's quite helpful.
That's the whole point with the F12, because it enters this code. We can actually search on it, because we can't search on easily on fit testing stuff. You'd have to go into things like TQuest, which is it's a lot more work. We don't really need to be doing that.
No, okay. So that's good tip. Thank you. Can I just ask on the call, is everyone clear about how to start that process that Caroline showed us all? And happy to and understand how they can use the F12 key. I don't know if there's anyone who doesn't use them. I'm just scanning the messages, but that's good. It all looks fine. Good. Okay. There is one note that someone's put in around words that the lab use, Seema, and I wondered whether I could ask you about that. So the question again came from Tina and said, when we get any result back from the lab, it seems the sample type is recorded as blood as opposed to stool. I might guess why that is, but you might have a more precise answer.
I'm not sure about that. I've not seen that. I think the main thing with that is making sure that the SNOMED code is correct. But yeah, I've actually not seen that. Yes. I think make sure that the SNOMED coding is correct. If you're having any issues with that, then I think follow the process that Caroline demonstrated. I'm here in case you need to contact, and as are the other people on the call. Please let us know how you get on.
Thank you. And then I've got a supplementary question, Caroline, from Luke from the Brondesbury practice. So Luke's saying, and you might want to speak your question, Luke. Do you want to speak it or do you want me to read it?
I can speak it, that's all right.
Thank you. Thanks, Luke. Yeah.
do the reception team use an F12 code to say that the fit sample has been returned back when they receive it, or do you just wait for results to know that the patient has completed the sample for you?
Don't use the F12 to say that they've come back, because they come back through all sorts of modes and how they can come in and just leave them in a basket. They don't need to speak to anybody. But we use the search facility. So the search facility will say these are the people that were asked to do the test, and then our results will then tell us, because the results are coming in, we can search on them. So, but there's no reason you couldn't. If you had a system where you've got one person and everybody delivers it back through the same place, the channel, you could do it that way if you wanted to.
Brilliant, thank you.
That's great, thank you. Great, okay. Are there any other snippets, Caroline, you want to add in for today?
No, with the fit testing, I just think it's just the awareness for the practice managers, and then looking at systems for our clinicians, but also for our locums, and how we can encourage patients to do the fit testing, and how we can ensure that we're getting the results back. We're not losing them. We're not getting patients coming back. They are coming back from the labs. Just to tighten up on that, I think it's all part of the sort of 2-week wait monitoring that we do, and CQC would focus on this particularly as a quality improvement. It impacts on patients' experience, it impacts on the pathways and clinical, and I think it's a really good quality improvement, and it's a measurable one.
Yes, that's absolutely okay. Seema, is there anything else that you would like to add? I think you just put something in the chat.
Yeah, I was just answering Tanya's message.
Question. Okay,
yeah, I don't think there's anything else from me.
Okay, so I've got a couple of points, short points. One is, I don't know how many of you still use locum packs when you have locums or sort of equivalent locums coming into practice, but we've been talking at the Alliance about putting together essentially some kind of crib sheets that you could include in locum packs. Would that be helpful to you, or do you not use them anymore?
Oh, I put my hand up for that, Claire. Absolutely, because our local
that would be
packs
helpful.
They would be. Because the other thing I was going to add in here, anybody who's moving towards a total triage model might want to start thinking about, when these questions come through on total triage, about getting that fit testing out, but recording that you've asked patients to do that as well. But yes, locums are always a bit of a worry. They come in and you may even have regular ones, but keeping them up to date and safety netting their work, I'd really
It's hard, isn't it?
Yes, it is hard.
So you raise a really good point. I mean, for those people that are going to total triage models, or are using lots of telephone triage or telephone appointments, I think from your perspective as people who keep the practice going and run the management and the admin, I think one thing that's worth us underlining is that the fit test is, you need to regard it, the clinicians need to regard it as a diagnostic test that moves the patient along the pathway, and as Seema said in her presentation, helps the clinician decide which pathway ultimately to take for that patient. Therefore, the best time to do a fit test is when a patient first presents with symptoms that may indicate that they have pathology in their bowel. So one could easily imagine that happening at a triage appointment or a telephone appointment. And at that time, ideally, the patient will be asked to do some bloods and do a fit test. And then they would be coming back for their results, but their results at that point probably need to be face to face, so that the clinician can examine the patient, because that's what's necessary. So a combination of the history, the tests that are needed to understand the problem better, and then examining the patient to put it all together. So if you have clinicians in your practices that like to ask for a fit test at the moment of referring rather than before, then it would be helpful to see if they would consider doing a fit test before, so they're using the result of the fit test to help them decide which of the various referral pathways to choose. because not all of these patients will be sent down a 2-week wait referral pathway. They might be sent down a pathway called Fit Less Than 10 pathway, which is a completely different pathway, or indeed it might be decided they don't have a bowel issue at all and they have another issue and may need to pass on to one of the other pathways like gynecology or something like that. So it's really important that now people understand that nowadays, and this is a bit different from what NHS England used to talk about a year and a half ago, but nowadays FIT is a test that you do at the beginning of your pathway, and its result helps you as a clinician choose what happens to the patient after that. Caroline, you've got your hand up, and then Deborah.
Oh, I shouldn't have my hand up. Sorry, that was
Okay.
that was for the
That's
local
okay.
pack. I was excited.
Good. Okay. So you feel so strongly about it. That's excellent.
Yeah,
Okay,
absolutely.
let me bring in Deborah. Thanks.
Yes, I'm not a clinician, but I tend to audit this and look and try and work out what's gone wrong.
Yeah.
We not often, but sometimes the patient, they do the fit test early on. The patient goes around the houses and everything else, and then they start to what the clinician sees as red flags, and then they refer them, but the fit test is now over 21 days. So they've actually had their fit test and everything else, and the clinician is actually thinking they've been around the houses, I've got red flags, but they're not these mass or the ulcerated anus. So
yes,
it's tricky really, because
that is tricky from a clinical perspective. If it depends how far away it is from the 21 days. So a lot of the hospital protocols use a longer cutoff, but if you, at the moment, the way that the NHS England rewards practices in terms of payments means that they're using a 21-day cutoff at the moment. So you might need to redo it. And in fact, there is evidence to say, to show us that in some patients that initially have a negative fit, they can, depending on their particular symptoms, they can convert over time. And the normal minimum time slot at that point is about 8 weeks. From a clinical perspective, I think the thing is we're dealing with two things here. We're dealing with the dialogue of clinically using FIT, and also understanding how the government is facilitating and rewarding patients for practices, for actually having done the test at all. So I think being pragmatic, you would need to repeat the test if you breach that window. Would you agree, Caroline and Seema?
Yeah, I think if you've got the window, it's setting up the system, isn't it? I think the difference with the diagnostics is it's linked to 2-week referrals. So that in our head straight away flags up, red flag, we've got timelines 2 weeks in our heads. But actually, what I'm learning now is it's the diagnostics, but you still don't want the patient to go away and not come back for 4 weeks or 5 weeks, because you may want to follow that patient up if they haven't done the fit test. They're not going to get a referral.
So that's right.
Yeah.
So I think you first of all need to do the right thing clinically.
Yeah.
And so if as you say, Deborah, as the pathway progresses, then further red flags appear, then I think at that point the doctor makes the decision to refer. They will have had a fit test from, as you said, perhaps 4 weeks ago or 5 weeks ago, and they can still put that. It's still valuable to put that result. In fact, they should put that result in the 2-week wait referral, but next to it they can just annotate it as the date this was done. That's separate for how they'll be paid for it.
They do that, but we just banging our head against the brick wall with the computer says no, with the the IIF, which is just it's painful and it's annoying. I think
it is annoying. There comes a point where you may need to repeat it, but what the reason I mentioned that bit of research work around repeated fits, we certainly know that in some patients they do change, and those are also patients that often have changing clinical signs and other clinical tests. So in that group, it would not be double work from a clinical value perspective to repeat the fit test, in that you might see a change or a progression in the result which would be helpful to the hospital that you're referring the patient on to.
Deborah, could I just ask, do you know if that's quite common that you're having this? Is it the odd one, or is there quite a volume of patients?
It's not a huge volume, but of the ones that aren't hitting the target, there's always one or two in there that are basically they've had a fit test, but it's out of thing. I mean, our other thing is that because we have a lot of doctors with portfolio careers, they tend to give the fit test, do the fit test, but we're really hot on coding, and so they've all been indoctrinated. They must code everything, so they do their referral sitting there waiting for the fit test result, but it's already coded and then it goes off.
But that's the problem, isn't it?
I know,
then?
It is the problem,
because you're not using it. You're actually breaking away from the national guidelines doing that. So what you need to say to your clinicians is that it's not in the national guideline to do that. In the national guideline, what you need to do is use FIT, NHS England, and the sort of czar for cancer for NHS England feels really strongly and has spoken lots about this, that you need to use the result of FIT to help you decide which of your referral pathways is the right one for that patient.
Yeah, so what I would add into that, Deborah, is actually that F12 function that I'm talking about is probably a good substitute for that, because it's like a safety net. They're in the system, you're waiting for the F12 for the fit test. If they don't come with the fit test, then a clinician can get involved and make a decision rather than creating the referral the other way round. What I was going to suggest is if you capture the data, when we're having our NCL practice managers meeting, we might bring this up, because if you've got a few, but everybody's got a few, then there's something about capturing that data and going back saying these are the ones that are being excluded. And what Claire's saying with her evidence is to turn around and say, well, actually, maybe the timelines we need to think about things differently, because it's going to be more costly to get the patient to repeat the test than it is if it's a valid test. But it's just not within their timeline because the computer says no.
I think you raise a really valid point, Caroline, and the sorts of meetings I go to at NHS England, they're always looking for evidenced comments.
Yeah.
So if one can say, here we are, we audited what was happening in our practices in NCL, and actually for X of them this happens, then that's much more meaningful for NHS England and is much more likely to get them to change their payment protocols, actually.
Yeah.
So so in fact, doing all of this, encoding properly and doing the using F12 would allow us better to understand how people are using the test, wouldn't it, Caroline?
Absolutely. And I think it will just give somebody another thought of how do you manage your locums, how do you safety net your potential 2-week referrals, which is what we're trying to do. But we're looking at fit testing very differently. If the doctor said, I might refer you, but I need you to get a full blood count, we haven't got systems in place to check that they won't have their full blood count. But because we link this to a cancer referral, everybody gets a little bit, let's get this referral ready. But actually, they haven't even had the result yet. And you're not alone. I'm not criticising you, because we were doing similar. So we've had to change how we're doing stuff and how we're approaching things, but with the same mind, Deborah, that we want to safety net.
Yeah, I think it's also about the doctors not wanting to give their work to other doctors, because basically if they only work portfolio careers, they don't want, the fit comes back within a day or so. So often but they're not going to be back for a week. Therefore, somebody else has to do the referral. So
I think that the practices. I think that's the sort of thing you might need to take to a practice meeting with the partners to say, we need to be aware that the fit test is best used. You don't do fit test to get money. You do fit test to help you decide which is the most appropriate direction for a patient to go on the various pathway options. So that and how do we as a practice help that? So it might be that one has to search and do searches for results that have come back as a whole practice, perhaps, and then manage it that way. The other thing is, to be honest, if they're back 5 days afterwards rather than 1 day afterwards, it's not going to make a significant. It really is not going to make a significant difference to the patient's experience with bowel cancer. Some cancers move very, very quickly, but bowel cancer doesn't fall into that group. Clearly, we don't want to have waits that are weeks and weeks and weeks, but a few days where a fit test is really helpful, means that it's a valid few days to wait, I think. But clearly it does require being careful about safety netting. I think, Caroline, on the safety netting toolkit that you can use there are different toolkits, but the one that we use as our favoured toolkit in the Alliance does have separate pages for you to use for doing other tests.
That's
So
right.
you could then put your blood count in there if you get used to running that system.
Yeah.
I can see as we're coming, I wanted to answer Raste Fatah's comment talking about the IIF and the previous years. I mean, in fact, the reason why NHS England moved it from 14 days before to 7 days after to front loading it was that they didn't want to leave any, they wanted all fit tests to be used at the beginning of a diagnostic pathway. So that's why they've changed it. That's what led to that. There's another comment in the chat, Caroline, saying, could you please show what protocol I think to use for F12?
Yeah, I can't do it now because I haven't got my EMIS going. But what I will do, I will pull my F12 protocol to show you what I've done, and I will pull up my search that matches how you search for that. And if I can pull it together in a nice email and pass it on to the Alliance, and they can share it out to the people that were attending, more than happy to do that.
Okay, no, that'd be really helpful. Yeah. Okay, so we're coming to the end of the webinar. Are there any other questions? So I'm just going to take, it's been really, really helpful, and your comments are really useful. And I think that if we all think about trying to use an F12 option for this, it would, as Caroline described early on, allow us from an administrative perspective to be able to more easily assess what's going on in practice, and if we've got fit tests that are falling outside for the best reasons, are falling outside measurement timeframes. If that starts to be a pattern and it's picked up across the whole of NCL, then that certainly would allow us to contribute to the dialogue. We have meetings, all the alliances get together in November every year. And so actually, if one had any messaging one wanted to take back to that meeting, it's a meeting I go to that all the clinical directors of all the 21 alliances meet together with NHS England, then we certainly would do. So if you wanted to get your F12s up and running quickly and let Caroline know, then we might be able to do something constructive with that for our next meeting in November. The last thing I'd like to say is not only about FIT, which is just to remind everybody that we run, from the Alliance's perspective, lots of different webinars, subject-specific webinars on lots of different things, clinical and non-clinical. Trying to reach out to the whole workforce. But the way we have to do it now because of GDPR is if a person, whether they're clinician or non-clinician, lets us advises us that they want to be on our mailing list, and we can do that by registering as Amelia has put in the chat there with us. We only need a registration once in a year. Then what that means is we can then send you all the invites, and they just sit in your Microsoft Teams diaries or in your email, so that it's particularly if you're the sort of person that uses the MS Teams diary, you'll find that you'll see it immediately that it's available. And we tend to use we try to use lunch times on different days of the week, and so if you want company while you're eating a sandwich or something, then why not join us on one of our webinars? But we would send automatically the invites to you so that it's there ready and waiting if you want to join. But we do need an initial contact from you. So obviously for the people on this call, I think we have an initial contact, but for all your doctors and nurses and other interested individuals in your practices, you might want to ask them to do that registration so that they're not missing out on education. And then, you know, whether an individual actually joins a particular webinar obviously becomes their choice or not, but at least it's sitting already in their diary. They don't have to remember it's there, and they don't have to go and look through 1,000 emails to find the one that has the link on it. So I hope that might be helpful in the future for some of you. As we close in the last 2 minutes, a big thank you to all of you for helping us further the FIT agenda. I mean, early diagnosis makes a massive change in the situation of patients with bowel cancer. So if you're diagnosed at stage 1, you have a 95% chance of survival, and if you have a diagnosis at stage 4, it's 5%. So it goes from 95 to 5% over those 4 stages of cancer at diagnosis. So it's really important that we can diagnose people early. And I'm really grateful for all your help in this. Okay, thank you very, very much. If you've got other subject matters you want us to cover, just put it in this chat at the end of the meeting here, and we'll have a look and see if we can, anything at all that's related to cancer. We'd be really interested to hear from you, and we'll certainly try and put something together if that's the case. Thank you.
That's great.